Okay, Bismillah ar-Rahman ar-Rahim. Today we are talking about very important topic in anesthesia. It is acute pain management. And as you know, acute pain management is a part of our daily work because one type of acute pain management is post-operative pain. And post-operative pain should be included in the management of all patients undergoing anesthesia in our daily practice. From this fact comes the importance of this topic. And as we are now in the August and the weather is so hot, we can start by this question. What's the relation of hot weather with the opioid? This question already have asked in the last year when you were in the first year. Every year I used to ask the same question because it's so important. What's the relationship of hot weather with the opioid? And who can explain the ultraviolet index in your iPhone? As the smart iPhone, all of them report ultraviolet index. What does that mean, ultraviolet index? And what is the importance in anesthesia of this continuous reporting of ultraviolet index? The answer that the ultraviolet index provides a daily forecast of the expected risk of overexposure to the sun. For example, the risk for melanoma and the risk for the malignant tumor, which is named as basal cell carcinoma. Actually, we are not familiar with these two diseases, but if you have any friend specialized in dermatology, he will tell you that these two important diseases very common in Iraq due to the high levels of hot degrees in the weather, especially in the months of June, July, and August. And the index predicts ultraviolet intensity levels on a scale of 1 to 11 plus, where 1 indicates a low risk of overexposure and 11 plus signifies an extreme risk. The relation with the anesthesia and our daily practice, according to a study, a new mouse study has found that continuous exposure to ultraviolet radiation causes the release of endorphins, known as feel-good hormones, leading to physical dependence, tolerance, and addiction-like behavior in the rodents. So may be resistant to morphine and need more analgesia, as the effect of endorphin, which are endogenous opioids, is similarized to the effect of exogenous opioids. And these may lead to the tolerance, which means required more doses to produce the same previous effect can be gated by less doses. This is a statement. When you do what's optimal ethically, then you would glorify yourself and please others. When you don't do what's optimal ethically, then you would harm yourself only. I wanted to hear from your side any comment about this statement. عبد الرحمن Khalid,
نعم أستاذ.
your opinion.
عم يعني واضحة، هو دا يقول يعني أنت من تسوي الشيء اللي تشوفه أفضل أخلاقيا، يعني راح تفيد نفسك وتفيد غيرك، أيضا تطلع بمظهر زين وأيضا المريض يستفاد. والعكس صحيح، يعني أنت ما تسوي اللي تشوفه صحيح أخلاقيا، فراح تضر نفسك أولا.
أي actually will harm yourself only. آخرين ما راح ينضر. Any one of you have any example or application about this statement in our life? مالكم ما هستحجون بالعيد. I will say the parents, father, mother, إذا أنت تبرهم لوالديك، إذا تأدي واجبك الحقيقي والصحيح والمطلوب اتجاههم، فأنت will glorify yourself، يعني تمجد نفسك والناس تمجدك والناس تحترمك. وفي نفس الوقت أنت في نفس الوقت راح تسعد. بس خل أسوي ميوت للصوت اللي دا يطلع. أوكي. وفي نفس الوقت راح تسعد والديك لأنه يحسون إنه أنت قمت بواجبك اتجاههم. بس إذا أنت حاشا أي واحد منكم ما يبر والديه، ما يؤدي واجبه المطلوب اتجاههم، فالحقيقة دا يسيء لنفسه، لأنه ما حد راح يقول أنه الوالدين هم السبب، وإنما هذا الشخص هو اللي أساء إلى نفسه لأنه لم يقم بالواجب المطلوب اتجاه والديه. This fact can be applied in many of our daily situations, and we have to consider that to do what are demanded from us in the daily situations to glorify ourselves first and please others. Regarding, return back to our presentation, the overview of this presentation will include the introduction regarding the pain management, multimodal analgesia for acute pain, PCA, which is patient control analgesia mode used in the post-operative pain management, and modes used in labor pain management, the most updated mode in labor pain management. Actually, the last 2 points will be covered mainly in specific presentation by Assistant Prof. Dr. Ali Hadi, maybe in the next week or the week after the next week. But we will talk briefly about the updated mode regarding the labor pain management. And we have, whenever we talk about pain, we have to start by the definition of pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in a term of such damage. This definition, according to International Association for the Study of Pain, has been stated since 1979. But this definition is so solid definition until now it is so depended by all those who work in the pain. Why? Because this definition includes many important principles regarding the management of pain. In this definition, there is implication of emotional component in addition to sensory unpleasant experience. And also there is a emphasis about the pain can exist without tissue damage. It includes the pain in association of actual or potential tissue damage or described in a term of such damage. The description will be in a term of such damage when there is pain without tissue damage. And as you know that the pain mainly according to this definition mainly is subjective, and whatever the patient say, whenever the patient say I have a pain, we have to consider that and deal with this patient as a patient has a pain. And there may be a criticism for this definition that the patient may lie and he or she does not has a pain. We said yes, but answer that by another question. How can you prove that this patient does not have a pain? We have no tool to measure a pain. The measurement of blood pressure, of pulse rate, all these measuring by objective methods. But the pain, we have no tool to measure the pain objectively. And the pain should be measured by subjective tool. And we have no way, only single way to consider what the patient feel about pain is a pain. And pain can be acute pain and chronic pain. And in this presentation, we will talk only about acute pain, and we have another presentation focusing on the chronic pain. And to know what is acute pain, we have to know what's a chronic pain. Chronic pain, we have actually many definitions for the chronic pain. And according to American Chronic Pain Association, the definition is pain that continues a month or beyond the usual recovery period, a month or more. Actually, this is the most beautiful definition of chronic pain I have ever seen in my life. The definition states that different periods, different duration to regard the pain as a chronic pain according to usual recovery period of the cause of pain. For example, if the patient complain, for example, of, for example, let's say post-operative pain. Post-operative pain for hernia repair, the usual recovery period in longer time is 1 week. 1 week. If the pain persists 1 month after this 1 week, we consider it as a chronic pain. And if the cause of pain was, for example, pneumonia, and the usual recovery from this pain is three weeks. If the pain persists after the 3 weeks by 1 month, we can consider it as chronic pain. So according to this definition, we have different duration for different causes of chronic pain. And another definition for this chronic pain, for example, describe the chronic pain as a pain persisting more than 3 months, and some may prolong the duration to consider the chronic pain when the pain extends to 6 months and can you imagine that the patient complained of 6 months to deal with him as chronic pain? It actually, from practical point of view, is unpractical. So I have seen that the first definition is more practical to deal with the patient as a chronic pain. And you may ask, what is the difference if we consider it acute pain or chronic pain? My answer will be that there are several modalities of the management specific for chronic pain and cannot be applied for the patient with acute pain. And this is the reason that why we have to define precisely the chronic pain, because from practical point of view, we have to manage the patient according to the type of pain, whether it was acute pain or chronic pain. According to this definition, we can say all pain is acute pain till it becomes a chronic pain after the period considered in one of the definitions above, according to the protocol of the pain clinic unit or hospital or countries. What are the consequences of acute pain? It first hurts and it is uncomfortable for the patient. Second, may lead to multimorbidities, and if does not manage as acute pain, will be converted to chronic pain. The types of acute pain, we have main interest in the post-operative pain in our daily practice, but there are several other types of acute pain. One of them is the trauma, and we may face the trauma in the casualty in patient presented with road traffic accident, multiple bullet injury, fall from height, and also other types of acute pain are the burn, patient with burn, and the anesthetist also involved in the management of patient with burn. And the fourth type is medical illnesses. Some medical illnesses associated with severe pain, and this pain may be consult the pain clinic to be managed from all the departments in the hospital. For example, pneumonia, abdominal pain, thoracic pain, lower limb pain, upper limb pain, headache. All these medical illnesses involved in the under the headline of acute pain. And the fifth type of acute pain is labor pain. And also we are involved in the management of labor pain through painless labor maneuvers. We'll talk specifically now about postoperative pain. The adverse effect of unrelieved pain. Yeah. If we leave a postoperative pain without management, if the patient postoperatively suffering of pain, what are the consequences of this pain? This pain can produce several physiological changes for most of our systems in the body. Regarding the cardiovascular system, this pain can trigger an increasing heart rate, increased blood pressure, increased myocardial auto demand, hypercoagulability, unstable angina, myocardial infarction, DVT, pulmonary embolisms. Each one of these complications is enough to produce morbidity and mortality. And from this point of view, we have to consider the post-operative pain seriously. As you may did a lot of efforts to give anesthesia for 70 years old patient with history of, for example, hypertension, ischemic heart disease, diabetes mellitus, and you successfully anesthetize this patient and discharge it from the theater to the ward. And after all these efforts from you, other paramedical staff, the surgeon, you will surprise the next day that this patient died. How did he die? The answer will be all of a sudden he died. Actually, the cause of this death is the pain. Most likely the pain. So sometimes it is so important, and sometimes maybe more important to manage post-operative pain than intraoperative pain. Sometimes it is more important. أفنان علاء.
نعم أستاذ.
Why أفنان? I said sometimes it is more important to manage operative pain than intraoperative. Why?
عفوا أستاذ، حتى نقلل الموربيديتي اللي associated with pain.
Okay, Afnan. Okay, thank you. Because intraoperatively, the patient, we have all of you, we have the triad of anesthesia, we have hypnosis, muscle relaxant, and analgesia, and intraoperatively, the patient under controlled ventilation, no big efforts done by the patient to take a breath, and under maybe 100% oxygen. So the morbidity and mortality less than that with post-operative pain when the patient complaining of the pain and he or she is not under controlled ventilation, maybe spontaneously breathing of room air, 21% oxygen, and the development of cardiovascular complications. Such circumstances will produce more harmful effects that occur intraoperatively. Now we will talk about the complication of pain regarding the respiratory system. It can decrease lung volume, decrease the cough, ability to cough, lead to retention of secretion, produce atelectasis, pneumonia, hypoxia. And regarding the GIT system, there may be decrease in the gastric emptying time, decrease bowel motility, and may cause constipation, anorexia, and ileus. And if we continue regarding the endocrine, may alter release of multiple hormones and causes hyperglycemia, weight loss, muscle wasting, impaired wound healing, impaired immune function. And regarding the musculoskeletal system, the pain can produce muscle spasm, impaired muscle mobility and function, and may cause immobility, weakness, and fatigue. Also, pain can produce effect on psychological situation of the patient and lead to anxiety, fear, sleep deprivation, and post-traumatic stress disorder. Here there is a study done by Perkins and Kelt and published in very important journal in anesthesiology at 2000. And at that time, this study produced very surprise for all who are working with the pain due to the horrible percents of post-operative pain in relation to multiple operations, surgical operations. According to this study, the thoracotomy, the incidence of chronic pain, about 30 to 67. And for limb amputation, about 30 to 83. For mastectomy, 11 to 49. For open cholecystectomy, 22 to 37. And for open hernia repair, about 0 to 37. قبل أن أكمل هاي دا تطلع شخوط على السلايدات، يعني هاي من يمكم؟ هسه هذا الشخط شنو هذا؟ وهذا ما أعرف شنو هذا. أكو واحد من يمكم دا تطلع؟ لأن أنا ما دا أحرك بتشو دا تطلع هيك شو.
ولا ينساب يعني ظهر واختفى.
اي لا كل ساعه غير هذا هم قبل شويه اكثر من مره طلعت هاي الشخوط، بس انا ما دا احرك اي شيء.
بالضبط هو PDF.
استاذ الصور هاي بالبرزنتيشن نفسه.
لا PDF الصور لو.
اوكي شباب. return back to the subject. First point, you have to know that this thesis published in very respected journal. And we cannot ignore such thesis because it published in very important, one of maybe higher score journals and related to anesthesia, in relation to anesthesia. The second thing I would like to ask you, why diverse in the number? Yani here 30 to 67, here 30 to 83. There is big difference between the two numbers in front of each operation. Do you have any idea here from 0 to 37?
استاذ البين موضوع سبجكتيف فيختلف من شخص الى اخر.
Okay, good. Do you have
dermatome استاذ؟
what? Dermatomes. Okay. بعد
استاذ حجم الانسجين.
يعني خل اقرب لكم فد شيء.
مرحبا استاذ.
اهلا وسهلا.
استاذ يعني اكو باللم امبيوتيشن اكو ريسك مال فانتوم لم فيبقون يعني نيوروباثيك بين يصير عندهم for long time period.
Good. خل اقرب لكم المعنى. يعني لو اني one of you
يعني one nation to another.
صوتك متقطع ما افتهمت. خل اقرب لكم.
استاذ ممكن يعتمد على مقدار التشو دمج اللي يصير.
اوكي خلنا أقرب لكم المعنى شوي. If any one of you has conducted a thesis for any of post-operative pain of this operation, at the end of the thesis, the result will be single number or such a range.
العفو استاذ الصوت مو واضح.
العفو استاذ، بداية السؤال الصوت يعني وقف وقطع فما فهمنا السؤال كامل.
If any one of you have conducted a thesis, at end of this thesis, at the end, the result will be precise number or a range of numbers.
Range of numbers, استاذ.
No.
Precise number استاذ.
Precise number. At the end of thesis should be precise number, according to the result have been collected and statistically dealt with. But this is the importance of this thesis. It is not a thesis that has been done by single team. This thesis is a meta-analysis. That is to say, there is a team collect all the theses related to post-operative chronic pain management and deal with them statistically and produce other results from the collection of all theses have been done in this regard. And accordingly here, when the thesis concluded that post-thoracotomy pain is 30 to 67, means that the number range between different theses regarding the post-thoracotomy pain syndrome range between 30 and 67. And for limb amputation, range between 30 and 83. And for mastectomy, range between 11 and 49. And if we just focus on the first number, 30, 30, 11, 22, 0, and if we accept the 0, all these numbers are high. All these numbers, first number. 30% from thoracotomy is high. 30% from limb amputation is high. 11% from mastectomy after mastectomy is high. Why high? Because here we are not talking about the acute pain management here. Here we are talking about what? About chronic pain management. Chronic pain management. So the acute pain management after these operations, acute pain about these operations are normal. But the problem and the abnormal that these high percents of conversion of acute pain to chronic pain after these types of surgery. And you may surprised about how can thoracotomy produce chronic pain, how can mastectomy produce acute chronic pain, but we are working in chronic pain management, and we frequently see all these types of post-operative pain, all these types. يعني ممكن واحد هو يسوي له نقدر نعتبرها moderate type of surgery اللي هي الهرنيا ريبير، وممكن يجيك يقول لك I have a pain, severe pain for the last 3 years after what? After operation for hernia repair. يعني can you imagine moderate surgery, hernia repair, can result in a pain all over your life after the operation. Okay, return back that all chronic pain begins as acute pain. This is a fact. So what is the importance of this fact? Abdul Salam. Abdul Salam. Ahmed Najib.
نعم أستاذ أسمعك. عبد السلام.
Okay, Abdul Salam. What is the importance of this fact? All chronic pain begins as acute pain.
أستاذ الامبورتنس يعني إنه ماكو بين يبدي إنه ككرونيك، يعني هو كله يبلش an acute pain progress to a chronic pain.
Okay, Abdul Salam. The importance of this fact that if you manage acute
pain
properly, you may avoid the incidence of chronic pain. The good management of acute pain can lead to decrease the incidence of chronic pain. Now, why we treat pain? It is a basic human right, no doubt about that. It is one of the basic human rights. Decrease pain and suffering of the patient, decrease complications of unrelieved pain, decrease chronic pain development, increase patient satisfaction, increase the speed of recovery, that causing decrease the length of stay, and this result in decrease in the cost, increase the productivity and the quality of life. All these are reasonable causes to treat pain. After all these facts, after our satisfaction that we have to manage pain, then pain may be till now, after all these facts, till now, pain may be undertreated. Why? What do you think the causes? Do you have any cause that till now the pain not managed properly?
دكتور لان بعض الاخصائيين يخافون من السايد افكت مال الدراجز ممكن.
Good. One.
أستاذ ممكن لأنه هم they got يعني towards the symptoms not the cause of the pain maybe.
Yes, two.
Both surgeon and anesthetist underestimate the pain.
No underestimation, because all other facts اللي طرحناها احنا, all these clarify the importance of pain management actually.
Maybe probably it is over exaggerated by the patient, so we can't get a true thing about the pain. We have to have a scale for it.
May some believe with that, but I will talk about the causes lead to under treatment, underrated the treatment of pain. First, physician may have concern that pain medications will worsen the hemodynamic instability. Now you are working in teaching hospitals, but in some other hospitals, I'm talking now about Iraq, some of anesthetists may haven't ever used any morphine all over his life. لأنه he believed that the morphine may the morphine lead to hemodynamic instability, lead to respiratory depression. May. So some physician may have concern that pain medication will worsen hemodynamic instability and can produce respiratory depression and failure. Medication produce harmful or long-lasting metabolites in the setting of multiple organ dysfunction. 3. Impair the ability to examine a patient's mental status. In Iraq, there is another social cause. Some anesthetists believe that when the patient left the theater shouting and crying, this is a good sign of complete recovery of the patient. And all the relative family of this patient will say that the patient left the theater aware and recovered from the anesthesia and surgery. This is absolutely opposite to our belief that the patient should leave the theater calm and relatively pain-free and in sedated, mild sedated state. However, this concern must be balanced against harmful effect of under treatment of pain. So we have to manage pain, and the management of pain based to be in multimodal way of management. Multimodal includes several ways and medications in the management of pain, starting by preemptive preventive management, local anesthesia, epidural anesthesia, and COX inhibitors, steroids, paracetamol, and opioid. Ahmed Qais.
نعم أستاذ.
What does it mean preemptive analgesia?
It means that we give a drug before the pain starts, because we anticipate that there will be pain. Like we when give, like for example, the triad of anesthesia, the pain have not yet started, but it will start after start of the surgery.
Okay, good, Ahmed. Means the giving of analgesia before the first stimulus and stimulus of pain. And the first stimulus of pain is the skin incision. So the giving of analgesia at induction time before the skin incision, call it preemptive analgesia. And the preemptive analgesia is an important factor to decrease and lower the post-operative pain. To manage pain, we have to assess pain. To manage pain, we have to assess pain. Why? First, to estimate the degree and nature of pain. The degree, is it mild, moderate, severe? Nature of pain, continuous, sporadic, with rest, continuous. To ensure patient comfort, to decide on type of analgesia, because the type of analgesia according to the severity of pain. To evaluate the effectiveness of or analgesia have been used previously. To help alleviate an anxiety, to aid recovery and prevent complications. When should pain be measured? We have two important times to measure pain. First, according to regular assessment, and usually asked when patients are at rest at fixed time intervals, just like the measurement of blood pressure, monitoring of pulse rate, auto saturation, consciousness level at fixed time intervals. And in any of these time intervals, the patient at rest. And the second way to measure the pain, and it is the better indicator, is assessment of pain during cough, deep breathing, or during movement. How to assess pain? By communication with the patient. It is important and essential way. Through this communication, you can assess the pain. And by observing for physiological signs and changes in these signs, increased blood pressure, increased pulse rate, increased respiratory rate, we can consider and assess the pain. So please consider pain as a fifth vital sign, and this is our hope and aim, to consider in the future pain as a fifth vital sign. And by using the scoring system, these are the different scoring systems. We have here 4 scoring systems, and they start by the patient able to communicate or not. If the patient unable to communicate, we can use the Faces Pain Assessment Scale, also known as Wong-Baker Faces Pain Rating Scale. And we will talk some details about each scale of these 4. If the patient able to communicate, we can choose one of these 3 tools, which are verbal rating scale, numerical rating scale, and visual analog scale. Verbal rating scales. Pain is described as none, mild, moderate, or severe. This is the usual way a patient expresses pain. This scale is short, easy to use and understand, especially in elderly and illiterate. Patient lack of reproducibility make this one less suitable for research purposes. So it is simple scale, can be used in many of our circumstances, but it is unsuitable for the research purpose. A numerical rating scale, it is most commonly used, and this the 2 extreme experiences of pain is noted and has a numerical scale between no pain and worst pain imaginable. 0 corresponds to no pain and 10 corresponds to the worst pain imaginable. The visual analog scale. It is similar to the numerical rating scale. There is a 10 centimeter horizontal line with a label of no pain at one end and worst pain imaginable at other end. The patient is asked to make on this line where he feels the intensity of his or her pain lies. The distance from no pain to this mark indicates the severity of pain numerically. The device has a line on the patient side and a numerical score on the clinician side. The visual analog scale is a simple, efficient, valid, and minimally intrusive method that correlates well with other reliable methods. The disadvantage is that it is more time-consuming than other instruments. There is some difficulty in using and understanding this scale in elderly patients. لذلك احنا قلنا بالelderly patient better to use verbal scale. The faces writing scale, it is commonly used. The patient is asked to point at various facial expressions ranging from a smiling face, no pain, to an extremely unhappy one, the worst possible pain. It is used when the communication with the patient is difficult, as with the pediatric and deaf and dumb patients. After the assessment of pain, we can categorize pain into mild, moderate, severe, and according to the severity of pain, we can decide the medications and maneuvers used to manage pain. For mild pain, for sure, we start by non-opioid, aspirin, non-steroidal anti-inflammatory drugs, or paracetamol. For moderate pain, we can add mild opioids like codeine with or without non-opioids. For severe pain, chronic opioid like morphine with or without non-opioids. Methods of administration of analgesics can be epidural analgesia, patient-controlled analgesia, either IV or epidural, intramuscular injection, subcutaneous, oral, rectal by suppositories, transdermal, inhalational, like nitrous gas, nitrous oxide, regional nerve block, like paravertebral, brachial plexus block, and by wound infiltration. Clinical effect of opioid-sparing analgesia or opioid-free analgesia. These are two important concepts of management of pain to either absolutely avoid the opioid in opioid-free analgesia or using only small amount of opioid in opioid-sparing analgesia. And actually, these two concepts start to be increased in the work daily practice for two important reasons. One of these reasons is increase the bariatric surgery. You know, in last maybe 15 years, increase the number of operation for bariatric surgery, and laparoscopic bariatric surgery. And those obese patients mainly very sensitive to the opioids and may cause a post-operative respiratory failure due to obstructive sleep apnea. So the concept of opioid-sparing analgesia and opioid-free analgesia start to be increased in the all over world daily practice. The benefit of these two concepts regarding the GIT system, less post-operative nausea and vomiting, earlier normalization of bowel function. And regarding the neurological symptom, less sedation, earlier normalization of sleep, and less fatigue. And regarding respiratory system, less respiratory depression, and for day case surgery, there is faster recovery, so less duration of patient stay in the hospital, and this is maybe cost effectiveness for the hospital. Generally speaking, we have to make a balance between the pain stimuli and the sequelae of pain stimuli, and between the side effect of opioid. The side effect of opioid, emesis, somnolence, and respiratory depression. And the pain stimuli lead to pain that causes physiological changes already mentioned. According to a balance for each patient, advantages and disadvantages, we can decide the importance of using opioid pre, per, and post-operative. How can we conduct painless operation without opioid in opioid-free analgesia? By using many alternatives in combination. I mean, not one of these alternatives. We can use a combination of several alternatives mentioned and listed here. Xylocaine IV infusion, ketamine, paracetamol, non-steroidal, nifopam, dexmedetomidine, and or clonidine. So by using a combination of these important analgesics, we can avoid the use of opioid and at the same time produce a pain-free operation with good analgesia. آمال ياسين.
نعم أستاذ، السلام عليكم.
عليكم السلام آمال.
الله يبارك فيكم.
What do you know about xylocaine?
شلون أستاذ العفو ماذا أسمع؟
What do you know about using of xylocaine?
أستاذ أنا اللي أعرفه إنه هو سيل ستابلايزر، يعني بحيث يعني إنه عن طريق إنه لقيت مات الصوديوم أو بحيث يعني مثلا توصل إنه يقلل الروتيشن مات السيل، فيقلل إنه البين اللي يصير.
اوكي.
وهو اوريدي استاذ يعني انه stabilization للبلد بريشر للبولس ريت، فبالتالي راح يقلل الديماند فيقلل عندنا البين.
Good. You are talking about IV xylocaine, right?
IV xylocaine ان شاء الله استاذ.
Yeah, IV xylocaine can be used as an analgesic effect in a doses of starting by 1 milligram per kg and followed by IV infusion in a dose of 1 milligram per kg per hour. And this xylocaine can produce a pain relief for many circumstances by central effect rather than the peripheral effect. And also we can add ketamine, paracetamol, non-steroidal, methopam. Non-steroidal, we have two important non-steroidal can be given by IV route, which are the ketorolac and diclofenac. I have seen certain European countries doing a lot of bariatric surgery without using of single drop of opioid, and all the patients are calm post-operatively without any complication. And this is was one of the question in the maybe the year before for the final board written exam in essay. Adjuvant can be used also to support the analgesia, and clonidine is one of the adjuvant, can be administered orally, intravenously, or perinaturally in combination with local anesthetic in peripheral regional anesthesia or in central venous and central actually neuroaxial regional block. However, the side effect could be significant. The side effect mainly are hypotension and sedation. You have to consider these two important side effects. And ketamine can be administered by oral, intramuscular, or intravenous routes, but it has also significant side effects. Regional analgesia, it is either continuous central neuroaxial block or continuous peripheral regional anesthesia, peripheral nerve block. And it can be achieved by two routes, either continuous epidural analgesia, the recommended first choice, and also there is continuous spinal analgesia, should be limited to the selected cases only as there is less experience with this technique. Most of you have done the continuous epidural analgesia, but with less experience regarding the continuous spinal analgesia. The advantages of epidural: reduced need of systemic opioids, reduced pain during mobilization, quicker return to normal bowel activity, reduced pulmonary complications, reduced hospital stay, and reduced chronification of pain. Continuous peripheral nerve block, they are being increasingly used since they may provide more selective but still excellent post-operative analgesia with reduced need for opioid over an extended period. Peripheral nerve block avoid the side effect associated with central neuroaxial blockades such as hypotension, تعرفون, spinal epidural associated with hypotension, and wide motor blockade. هنا ما عندنا wide motor blockade with reduced mobility and proprioception. And also to avoid the important hazardous complications such as epidural hematoma, epidural abscess, and paraparesis. now the trend towards the continuous peripheral nerve block. فإذا ناخذ عن example نشوف أنه for total knee replacement post-operative pain, previously this pain managed by epidural catheter, continuous epidural analgesia. In continuous epidural analgesia, there is no selective block. The block will involve the two lower limbs plus the pelvis area. After development of peripheral nerve block, we changed the practice from continuous epidural analgesia to femoral nerve block. Why? Because femoral nerve block is more selective. First. Second, with less involvement of motor function of lower limb. And the surgeon emphasized that the early mobilization of the patient post-operatively is the cornerstone of the success of total knee replacement surgery. So it was important to change the practice from continuous epidural analgesia to continuous peripheral nerve block analgesia. And after a while, they found that continuous femoral nerve block also, although it is selective, but also involve the decrease in the motor function of most of the thigh anterior compartment muscle that a bit interfere with early mobilization of the patient. And this leads to the changing of a practice from continuous femoral nerve block to continuous saphenous nerve block. Saphenous nerve block through adductor canal block, and the saphenous nerve is a terminal continuous branch of the femoral nerve. Saphenous nerve has no motor function, just sensory function, and affect mainly the below knee area rather than the involvement of the thigh. Can you imagine that the start was with epidural analgesia that involved both lower limbs plus the pelvic area, then changed to femoral nerve block, and after that converted to continuous saphenous nerve block. Also, we can get a benefit of infiltration block. Pain relief may be achieved by infiltration of the wound with local anesthetic. The technique is easy to perform at the time of surgery. The efficacy and the duration of analgesia depend on the length of the wound and the type of local anesthetic used. And this is, although it is so simple maneuver to be performed, but it is very effective and will produce very solid analgesia post-operatively. So please don't underestimate the infiltration block, which is important maneuver to manage post-operative pain, especially when you are in a theater that devoid of the ultrasound to do the required specific blocks for certain operations. And regarding the infiltration block, there is very famous post-operative infiltration block. Anyone have any idea about this famous infiltration post-operative surgery?
عفوا استاذ تاب بلوك افتر سجلت سكشن.
What?
Tab block after cesarean section?
Tab block, not infiltration block. Now I'm talking about infiltration block. يعني الانفلتريشن بلوك لما تخلصون السيزيريان قبل ما يسدون السبكوتينيوس ممكن يسوي انفلتريشن للوند و under the skin و produce very effective block. But there is important operation to be managed by infiltration block post-operatively and very effectively.
عفوا عمو اوبن كوليسيكتومي دائما احنا نشتغل سليمانيه.
Co-transition open prostatectomy.
بعد
استاذ هم hernia repair
بعد
ساعد وعندنا midline incision هم يسوون به.
بعد يسموها لايا تكنيك local infiltration of anesthetic يستخدموها بالtotal knee replacement. هاي layer technique, it is not a matter of infiltration below the skin, but at the time of the closure, starting from the intra-articular space, and with each layer of closing, there is infiltration of the layer by the surgeon himself till reaching the skin. This is a famous technique all over the world, but this is not so accepted by the anesthetist because the high doses of local anesthetic to be used in this technique. But I have seen that by Australian team doing this block routinely, and there are several pieces have been published in famous journals regarding the use of layer technique in post-operative after total knee replacement. They used higher doses than the allowed upper limit to avoid local anesthetic systemic toxicity. I have worked with this team here in Iraq, but I didn't permit to use their doses and just limit the dose to the allowed doses according to the textbook. They didn't accept that actually because they used to do their own maneuver without any complication. Steroids well documented in surgery and acute pain also benefit. The steroid cover both analgesia and less post-operative nausea and vomiting. The metabolic effect useful in cachexic patient. It is cheap, little side effect in short-term use, and the dexamethasone as adjuvant in peripheral nerve block is questionable because there are several concerns about the neurotoxicity of dexamethasone if used in adjuvant to local anesthetic in peripheral nerve block. So many recommend the use of dexamethasone IV in adjuvant to the peripheral nerve block. That is to say, injection of local anesthetic peripherally and giving of dexamethasone IV at the same time. There are theses concluded that this dexamethasone, IV dexamethasone, prolong the effect of local anesthetic if the giving of dexamethasone in the same time. What's patient-controlled analgesia? Patient-controlled analgesia uses a programmable syringe pump. It is actually originally just like a syringe pump, but this syringe pump is programmable to allow patients to self-administer their own intravenous or intraepidural or intraperipheral nerve block analgesia. PCA was first described in 1968. In the late 1980s, improvement in syringe pump technology allowed PCA to become available for general use. It can be used for either intravenous, intraepidural, and we can add the perineural of patient with continuous peripheral nerve block. Indication for use in patients with moderate to severe pain, unreasonable to be used for a mild pain, and the pain should require multiple doses of analgesia. And the use mainly in acute pain is unreasonable to be used in chronic pain. The contraindications, patients who are cognitively impaired, patients with limited understanding, confusion, or disorientation, patients who are physically unable to push the button. Note that may be used effectively by children. However, parents must be involved in this technique. The advantages of PCA: patients can titrate their analgesia to their pain. Patients are in control. Rapid response to demand for analgesia. Reduced patient anxiety compared with other analgesia techniques. Improved patient satisfaction. Reduces nursing workload. Advantages of PCA: potentially constant serum levels of analgesics. Smaller doses are more frequently prevent large peaks and troughs in the plasma concentrations. Easy titration for painful incidences such as physiotherapy. This is the analgesic corridor, and this is the level of good analgesia. If the analgesic level decrease, there will be a pain. If the analgesic level increase, there will be side effect. PCA helps to maintain the dose of analgesia within this corridor. It is computerized ambulatory drug delivery device. Include user-defined protocols, protocol library on pump, and pump reports. So this device includes protocols and a library of several protocols to be used, and continuous reports and monitoring of the current and previous uses of this device. The setting of this device is essential step in the using of the device. As I have just mentioned, there is a drug library and drug information. These all displayed on the screen, and there is a dosage calculator, so you can just set the weight, the dose, and there will be a calculation of the precise doses used for any specific patient, and provide alerts, clear indication when a protocol or dosing limits are not in use or have been overridden. Any abnormal or not even normal steps in during the work with continuous alarms and continuous display of the work. Here are 3 examples of patients to be managed by PCA. First is Katie, 5 years old, underwent appendectomy and now in pediatric intensive care ward. Helen, 38 weeks, pregnancy, underwent epidural pain relief in labor and delivery ward. Maureen, 68 years old, underwent knee replacement, now in post-operative recovery ward. All these 3 patients can be managed by PCA. And if you look at the protocols here, you will find that here there is pediatric intravenous PCA, and according to the weight, here we can choose the weight, and here we can choose the type of opioid, morphine, fentanyl, and with the dose. So it is a matter of choosing only. For Helen, here we have different modes of PCA. Here there is patient-controlled epidural analgesia. Patient-controlled epidural analgesia. Here there is 2 modes, which is programmable intermittent boluses, and here programmable patient continuous epidural analgesia. And here the mode is just continuous. We can use any of these 3 modes, and after that we choose the dose and the analgesic, whether it is just ropivacaine or ropivacaine with fentanyl, and the percent of the ropivacaine or using of bupivacaine with fentanyl. And for Marwin, there is the therapy through peripheral nerve block, and we can use it for hip, for knee, for shoulder, and also here we can use the required suitable local anesthetic and drugs. The setting, the device can be programmed to deliver patient demand only. According to our setting, we can deliver just the patient demand. Or we can use the device with a continuous infusion only, according to our wish. Or we can choose programmed intermittent boluses. Or we can choose 2 maneuvers, 2 modes, by combination of any of these 2 maneuvers. In the setting, drug concentration is important. The concentration of analgesia should be per ml, maybe either milligram per ml as with morphine or microgram per ml as with fentanyl. Loading dose and initial bolus of analgesia given prior to the commencement of patient control analgesia. This is an optional function. You can choose it or not. If you prefer to start by loading dose, you can choose it. If you don't prefer that, you can omit it. The drug concentration, we can dilute the drug. Here, 3 examples: morphine, pethidine, fentanyl. If we put 50 milligram of morphine, means 5 ampoules, 500 milligram of pethidine, 5 ampoules, 500 microgram of fentanyl, also 5 ampoules diluted with normal saline to a total of 50 ml. The concentration will be here 1 milligram per 1 ml of morphine, 10 milligram per 1 ml of pethidine, 10 microgram of 1 ml of fentanyl. I have talked about the bolus dose. The important option in the device is the lookout interval, which is the preset time in which the patient cannot receive another bolus dose via the PCA delivery system despite patient demand. It is a safety mechanism that prevents patient overdose, and the common lookout interval is 5 minutes. So many concern about the PCA that the patient can take overdose. The lookout is very important measures to prevent the overdose. If you put the lookout device every 5 minutes, according to your setting, maybe 5 minutes, 10 minutes, 15 minutes, up to you. But if you put the lookout time is 5 minutes and the patient want to get analgesia and push a button, he will take the analgesia. But after that, whatever the number of pushes of the button, will not take analgesia till the ending of 5 minutes. And after the ending of 5 minutes, if he push, he will get another push of the analgesia, and also again stop getting analgesics for 5 minutes. That is to say, if we put the lookout interval 5 minutes, means the patient can get 12 doses per hour, and this should be accounted according to the analgesic type, according to the dose set in the device, according to the severity of the pain that the patient complained of. Also, there is an option for background infusion, which is a continuous infusion administered via the PCA delivery system. It is optional. You can use it in addition to the patient control analgesia. For example, you can say that I want 10 ml per hour to be continuously infused in addition to the patient control analgesia controlled by the patient himself. And also there is an option of hourly dose limit, a preset dosage limit that prevents the patient receiving more than designated amount of analgesia within a set amount of time. This is an optional function and only programmed if prescribed. Patient assessment and monitoring during PCA. The monitoring of blood pressure, pulse rate, respiratory rate, sedation score, pain score on movement should be documented. To which time interval? At first, half hourly for 4 hours after commencement. Then hourly for 8 hours. Then every 2 hours for 12 hours. Then every 4 hours, then after. Additional monitoring and documentation, the respiratory depth and ability to deep breathe and cough, the side effects such as nausea, vomiting, or pruritus, SpO2 if required, any changes to the PCA prescriptions. Now, what's the situation in Iraq regarding the acute pain management? Unfortunately, till now, the acute pain management not well established in Iraq, and it is a matter of personal efforts in the hospitals according to personal relationships between the doctors in different branches. So we have no pain management unit for acute pain, no well-established acute pain management unit according to the skeleton of the hospitals. While scientifically and practically in each hospital, there should be acute pain management unit. And the person in charge of this pain management unit is an anesthesiologist, and there is a timetable about the duties of the anesthesiologist in the department of anesthesia to be in charge of this unit according to the time of work all over the week. منو بعد بيها هاي اليونت مفروض بيها بعد اكو ممرضة او مساعدة تخدير، اكو فد كاتبة ادارية. شنو البروتوكول مال العمل مال هاي الوحدة؟ هاي الوحدة البروتوكول مالتها عمل مالتها انه from all the departments of the hospital, any patient complaining of pain, despite of the using of classical analgesics, that this certain patient not responded well to this analgesic and still challenged to be quiet and manage to from pain. So there will be a consultation of this acute pain management unit by formal report about the patient and the complaint, about the cause of pain, about the analgesic already have been used for this patient. الطبيب من يجي يلقي الممرضة أو مساعدة التخدير محضرت له مثلا فد خلينا نقول 8 to 16 files of 8 to 16 patient. وكل patient في ردها من الردهات. واحد مثلا ردهة الباطنية، واحد بالهيماتولوجي، واحد بالسيرجيكال ووردز مثلا بالطابق الثاني، واحد بالطابق الخامس، واحد خلينا نقول وحده بالنسائيه. المهم عنده 8 الى 16 مريض، يسوي عليهم تور، ياخذ history، يسوي examination and decide the type and maneuver of and the analgesic to be suitable in the management of those patients. This is the main duties of the pain management unit, which is unfortunately till now not well established in Iraq. Some of you may be surprised and saying with themselves, then what about the pain management unit, for example, in Medical City or in Al Yarmouk? These are actually mainly chronic pain management unit rather than acute pain management unit. We can extend the work of chronic pain to involve the acute pain also, but I'm talking about the skeleton احكي عن هيكليه كامله لها علاقه بسياق عمل مع المستشفى. يعني ما دا احكي على بيرسونال ايفورتس. يعني هسه احنا بالكرونيك بين يونت مالتنا تجينا استشارات من الاي سي يو، من الردهات حقيقه، ونقوم بهذا العمل. يعني ندز اطباء ويروحون to manage those patients. بس هذا نقدر نسميه personal work. انا من دا احكي على institutional well established unit for acute pain management. This is the last section of our presentation today, the advances in labor analgesia. And here there's a beautiful statement: the delivery of the infant into the arms of conscious and pain-free mother is one of the most exciting and rewarding moments in the medicine. Actually, this is very beautiful and attractive statement, and any of you can feel the size of the happiness if he was or she was in such a situation, that the mother with her baby between her arms and conscious and pain-free and maybe lactating the baby. Unfortunately, also in Iraq, our situation is absolutely different from that statement. Here in Iraq, we can see frequently, all of you can see such, I can't actually describe such horrible situation during the delivery of the mother. The goals of labor analgesia: first, dramatically reduce pain of labor, allow parturients to participate in birthing experience, minimal motor block to allow ambulation. This is very important. Minimal motor block, allow only sensory block, minimal effects on the fetus, minimal effects on progress of labor. The techniques, I'm not talking about the basic and the principles of epidural analgesia. I already mentioned that you have a specific presentation by Assistant Prof. Dr. Ali Hadi, but this is just a few slides regarding the advances in the epidural analgesia for painless labor. We have multiple techniques. First, intermittent top-up bolus injections. Second, continuous epidural infusion. Third, patient-controlled epidural analgesia. Fourth, programmed intermittent epidural boluses. Fifth, combined two modes of the above, like patient-controlled epidural analgesia and the programmed intermittent epidural boluses at different concentrations. Here, the details may be now not important to be kept by your mind, because you can read it quietly after the end of this presentation. But here the concentrations and doses of the local anesthetics used in the intermittent top-up bolus injections, and the same for the continuous epidural infusion. And here the second technique, continuous infusion, will benefit better and continuous analgesia, reduce workload, and better maternal satisfaction. while the disadvantages: greater local anesthetic consumption, dense sensory block, increased risk of operative delivery. There is no consensus about these advantages and disadvantages, and you may find different opinion regarding the advantages and disadvantages of these different modes. Here, the patient control epidural analgesia compared to continuous epidural analgesia, there is decreased dose of local anesthetic, decreased motor block, increased maternal satisfaction. While the disadvantage, unilateral block, 25%, and this is according to Cabillo in Anesthesia and Analgesia journal at 2008. Regarding the program intermittent epidural boluses, also here mentioned the type of local anesthetic and the dose and the volume per hour. And in this slide, we can conclude that we can get a benefit of combining two modes for the same patient, which can produce a better result. And here also a combination of two modes, but with different concentrations of local anesthetic. And this results in reduction of the total local anesthetic dose, reduction of additional top-up doses, decrease of motor block, increase maternal satisfaction. Finally, optimal pain management is the right of all patients and the responsibility of all health professionals. Thank you very much. If you have any question or comment, I'm happy to hear from your side.
عاشت ايدك استاذ.
وإيدك.
عاشت ايدك استاذ. اذا ممكن سؤال بس.
تفضل. تفضل.
استاذ انت قلت البين ممكن يسوي لنا يعني هايبر كواجوليشن اذا بقى يعني بوست اوبراتيفلي. يعني اكو مثلا يعني مثل دي في تي او بي اي بالمونري امبوليزم يعني صايره هيك يعني ريجسترد كيسز.
اكيد. ولا انا هسه مو انا قلت هو بالحقيقه، يعني انا مجرد تعرف المحاضره هي a collection from different sources, textbooks مو and thesis مو papers. انا مو جايب ف should be اكو reported cases.
زين دكتور، يعني تعرف يعني الميكان الباثوفيزيولوجي مالتها، يعني شلون مثلا البين ممكن يسوي لنا هايبر كواجوليشن؟
ما اعرف، بس ممكن انه affect the good يعني blood flow. You know that the blood flow is important parameter to prevent the thrombosis formation and emboli showering.
عاشت ايدك استاذ.
العفو عمو، اكو علاقه بين الموبلايزيشن اند بين؟ يعني اكيد البيشنت من يكون عنده بين ما يصير عنده موبلايزيشن، ايرلي موبلايزيشن، في هذا يصير دي في تي، يصير ثرومبوسيس.
اي ممكن، نعم ممكن.
شكرا.
العفو استاذ اذا تسمح.
تفضل.
بس انا ومجموعه من الطلاب عندنا سؤال يعني خارج موضوع المحاضره، اذا ممكن بعد المحاضره.
خلصنا المحاضره، اذا ما عندكم سؤال خلصنا.
هو خارج موضوع المحاضره، على موضوع مواضيع البحوث اذا تسمح. اذا حضرتك عندك وقت.
تفضل.
يعني استاذ العفو، نواجه شويه صعوبه باختيار المواضيع، واكثر المواضيع اللي نحاول وندور عليها نلقاها اغلبهم مشتغليها، يعني اذا مو هنا برا، فاذا ممكن حضرتك تساعدنا يعني.
تقصد برا؟ ايش تقصد برا؟
يعني بدنا نلقاها المواضيع، يعني احنا ندور عليها مثلا، يعني نلقاها انه منشوره ببحوث بمكانات معينه، يعني بغير دول حتى.
اي هو اكو الحقيقه، هو اكو wide range of seeking about the topics of thesis. بس المشكله اللي انتم تواجهوها انه انتم تشلبون موضوعين ثلاثه، وهاي المواضيع يعني بالحقيقه مو بس مشتغليه وانما مستهلكه، يعني مستهلكه انتهت. يعني اذا واحد يسمع بيها يضحك علينا. يعني اغلب المواضيع اللي تجيني هي مواضيع لها علاقه بالاندوتراكيال انتيوبيشن والريسبونس لل ام اي انسيرشن، وهاي المواضيع هسه اقدر اطلع لك بالعراق يمكن فد 500 بحث مسوين بس هنا، بس بالبورد مالتنا. فما معقول احنا نشلب بموضوعين ثلاثه ونترك المواضيع المهمه. فاني سبق وان قلت لكم، انتم بعدكم مو هسه قلت لكم، يمكن قبل فد 6 اشهر قلت لكم لا تحصرون نفسكم في وقت وبعدين تقولون ما نلحق. يعني واحد من صف ثاني الى نهايه تقريبا نهايه خلينا نقول صف رابع، يعني عنده خلينا نقول اتليست سنتين ونص. هاي السنتين ونص يقدر يشتغل كل شيء اذا راد يعني يشتغل فعلا يعني اونستلي، فراح يدور بهاي مواضيع ممكن ان تكون مفيده. لكن هو اذا يحيط نفسه بليميتيشنز، هذا الموضوع راح يخليني اتعب، وهذا الموضوع لازم كذا، وهذا طبعا ما يلقي مواضيع، مستحيل راح يلقي مواضيع. انا هسه بجلسه واحده اقدر اطلع 500 موضوع للشغل، 500 موضوع، مو موضوع ولا اثنين ولا ثلاثه. بس اذا احدد نفسي بموضوعات معينه وموضوعات مستهلكه، طبعا ما راح اقدر القي موضوع، لانه يا اللي راح تجيب لي راح اقول لك هذا اشتغليه، هذا مشتغليه، هذا مشتغليه. فاولا تراي انه تحرر نفسك من موضوع الليميتيشنز، تراي انه توسع مساحه الاريا مالتك اوف وركينج، من خلالها راح تقدر تلقي مواضيع كلش هوايه. سمعوني مو؟
واضح استاذ عشتي.
اكو عندكم بعد سؤال او كومنت بالعلاقه بالمحاضره او بالبحوث؟ up to you.
استاذ زين، اكو مواضيع عن بحوث يعني احنا يعني مثلا كريجنال او شيء احنا ما نعرف نشتغلها، يعني هل بالامكان مثلا نختار الموضوع وبعدين مثلا بالمستقبل نتعلم التكنيك وبعدين نطبقه؟ يعني
هاي انت والسوبرفايزر. يعني مثلا هسه انت اذا تجيب لي موضوع، انا اقول لك هذا الموضوع اقدر اعلمك اياه بنص ساعه، هذا الموضوع اقدر اعلمك اياه بيوم، يومين، باسبوع، وتقدر تشتغله. او تجيب لي موضوع اقول لك هو هذا سهل، كل سهل، بس المشكله ما تقدر تشتغله لان ما عندك التولز اللي تخليك تشتغله. على سبيل المثال مثلا فد موضوع معين يعني ما متوفر عندك سونار على سبيل المثال بالمكان مال عملنا، او ما متوفر عندك مثلا خلينا نقول الانسترومنت اللي تحتاجها بالعمل. فهذا انت والمشرف. هو شنو فائده المشرف؟ فائده المشرف انه انت تجيب له مجموعه مواضيع، ممكن يقول لك هذا الموضوع كلش حلو بس انت ما تقدر تشتغله، هذا الموضوع كلش حلو بس مشتغليه هوايه، هذا الموضوع كلش حلو بس ما عندك التولز اللازمه اللي من خلالها تجمع بيه داتا. يعني هيك يصير الكوميونيكيشن. وانا سبق وان قلت لكم the most important step في موضوع البحث هو موضوع اختيار البحث. أهم خطوة في البحث هو موضوع اختيار البحث. وأنت يعني خلي في بالك أنت سواء سويت موضوع مرتب أو موضوع سلي، هو بالحالتين هو أنت سويت بحث وانحسب عليك، فحرامات هذا التعب والجهود وأنت مختار في الموضوع سلي ويعني مو مهم. فيعني لذلك أنا دائما أدعوكم أنه تختارون مواضيع يعني جيدة مرتبة.
اوكي، عشتي لك استاذ.
اكو بعد سؤال كمان؟ Thank you very much. مرة أخرى احنا بالعيد نقول لكم كل عام وانتم بخير، يحفظكم إن شاء الله ويوفقكم في مساعيكم ويدفع الوباء والبلاء عن الجميع. في أمان الله.
مع السلامة.